Started. Welcome, everybody. You are at our PATH CPI Southwest convening. I see lots of familiar faces, so I think we're not going to spend a whole lot of time talking about what PATH CPI is, but we have a ton of great information on our website. So if you're new to this group, I would encourage you to check it out. Next slide, please. As you saw as you entered, we are recording this event. And we will make the recording and slides and any links and information available on our website after the event. So keep your eyes out. Next slide, please. My name is Catherine Stewart, and I'm the Director of Learning and Action at the Population Health Innovation Lab. I'm joined by a number of my colleagues, many of which who have renamed themselves with Phil, P-H-I-L, in their name. So we're not going to spend time going through and introducing each person, but if you need anything during this meeting, please feel free to reach out and send a message to one of my colleagues. Next slide, please. So before we get started, we did want to go over quickly CPI participant eligibility. So this is a safe space, and we want to make it a space where we can all work together to discuss and solve, hopefully, the topical implementation challenges related to ECM and community supports. This is not a space where we want there to be any sort of solicitation to the participants. So if you're a vendor or anyone else that shouldn't be part of this group, we really kindly ask you to leave this meeting. But we do welcome the opportunity to connect with you. So if you would like to connect with us and have something you would like to share with our participants, please reach out and we can figure out another venue to do so. And in that same spirit, we are hoping that people would be willing to rename yourselves with your full name if it is not on there, and your organization as well. That way, all the participants know who's in the room with them. Next slide, please. I'm going to hand it over to my colleague, Jessica Sanchez, to do a land acknowledgement.
Yes, the Population Health Innovation Lab team respectfully acknowledges that we live and operate on the unceded land of Indigenous peoples throughout the United States. Today, I am working from the Tongva land, and I encourage you to click on the link that is in the chat, maybe a couple of chats up, to navigate that website and see which tribes reside in your current place of residence, and put them in the chat if you're interested. Next slide. And as a cross-sector collaborative with big aspirations, it is important to commit to community inclusivity. These 4 pillars are very helpful, created by the community health worker and promoter workforce development. I'll just highlight a couple that I think are really special. The first being present, brave, and curious, especially in this ever-changing landscape of CalAIM, and to embrace conflict, which can deepen our understanding. And just one more, and that is to respect each other's time and participate fully and prepare for what you're about to learn for today. Thank you.
Thank you, Jessica. So really quickly, I am going to go over the agenda and objectives for our meeting. So we are currently going through our welcome and framing. In a moment, we are super excited to be able to do a local organization spotlight with Community Supports Network. We always love the opportunity to highlight the amazing work that you are all doing on the ground. So if you're interested in being a spotlight at a future meeting, please let us know. We would love the opportunity to showcase your work. Following the spotlight, we are very fortunate to be joined today with folks from the Department of Healthcare Services, and they're going to do a presentation, and then we're going to have the opportunity to be in dialogue with them in a facilitated question and answer session. After that, we are also joined by our friends from Partnership Health Plan, who are going to provide a quick update on what's going on at Partnership, and then we will wrap up in next steps. So as with all of our meetings, one of the main objectives here is really to build relationships among all of you doing this important work, and to learn about Partnership Health Plan's improvements and resources to support implementation of community supports in ECM. And today we really are hoping to increase our understanding of the Population Health Management Initiative at DHCS and to clarify opportunities for cross-sector data sharing for improved care collaboration. Next slide, please. And now I'm going to hand it back over to Jessica, who's going to introduce our local organization spotlight.
Yeah. So each month we aim to spotlight an organization in the region that has approached CalAIM curiosity and innovation. The spotlight enables a platform for the organization to share their approaches to pain points and solutions to their ECM and community supports implementation journey. It also provides a space, as Catherine said, for networking and inspiration. And this month, I am pleased to give the spotlight to Community Supports Network. Their mission is to help individuals with behavioral health challenges realize their potential by providing hope, wellness, and high-quality supportive housing. So Kim, the floor is yours. Did you want to share your screen, or will you just be taking it away through Mike? I don't see you just yet. Oh,
Hi.
Hi.
Hello, my name is Kimberly Sintero. Thank you so much for that welcome and introduction. I'm wearing sunglasses because I had surgery on my face and I have a bruise and I didn't want to alarm anybody. So if you're comfortable with me taking them off, I can do that. You know, I'm fine with it, but I just wanted to, you know, so I'll do that. Anyway, so I'm grateful to be here. I know that I have 10 minutes and I love to talk. But I really want to, so what I would like to do is introduce the data we've collected and where we're at right now. So, because I think data is really important and it talks really about the work that we've done. So to date, as of this morning, since the onset of our program, which was when we officially opened this part of Community Support Network, which we are a CBO nonprofit here in Sonoma County. We're part of a CBO, and then we contracted with Partnership early 2022, and we received incentive pay. And so we were able to open up a care management department. From that, we launched officially in our county in October. And to date, we've housed successfully 150 people. And so I tell you that because that's a lot. It's a lot, and it's pretty amazing. Sorry, it's funny. But what I want to focus in on is that we had to learn a whole bunch of new language. We had to learn, and we were really supported by Partnership. We didn't know the language. We had never contracted with them before. We had no idea what we were doing. We spoke in acronyms. I didn't even understand what it all meant. But what I knew was the difference between the word care management and case management. They were two very different words. And what that did was enable us to build a whole person care team. And we could wrap around people and not manage cases, but manage care. And that was really important for us. So as we began to build, we collaborated and networked with many people in our community. Amy and Erica Chloe, we got so much support. We were a CBO that was we weren't at the table. We went to a big conference in Sacramento when I met folks from Department of Healthcare Services. We got invited to the CPI Collaborative. All of these pieces were really important for us because we began to feel like part of, and we were able to collaborate and network and talk to everybody. And so as a result, the members benefited. So we were able to reach out to people in a way. And as we built the team, you know, there were a lot of things, lessons learned. We just came from Boston, and some of the stuff we talked about was staff retention, self-care with staff, team building, and learning how to do this work differently. Because what we know didn't work in the past, we know some of the challenges. There's a lot of things that we know that could work. And now we were given the opportunity to implement it, and we've done that. And I'm really excited. The team that's been built here, everybody that comes here has some type of lived experience. I'm of that philosophy. All of us have some type of lived experience. We've been affected in many ways, family members, whatever it looks like. And that is very important. No, I don't have to sit down and tell you what my lived experience is, but I can come to you with empathy and care. So I want to be able to sit with you and walk alongside you. It's not enabling, it's support. It looks different. And people respond, and being patient and waiting. Sometimes, the referral lists weren't always good phone numbers, but if you just wait and you're patient long enough, they're going to show up somewhere, somehow, and you're going to be able to interact with people. But it really requires a lot of communication with us, partners, providers. I can't say enough about partnership. I have had experiences with all of the team, ECM and community supports and claiming and the medical director. And when I needed to advocate for somebody, I know that we're almost out of time and I know there's a full agenda, but I want to share this story. It's really important. There's so many things I want to talk to you about. There's so many variables. We also just were awarded Path Cited 2. And so we're going to be able to build even more. We have, and that was, Path cited funding, and we used the CPI Collaborative to help us get there. We took other people to help us, and we just reached out, and not be afraid and ask for help. We're not islands, and the Department of Healthcare Services has been there for us. And now we're going to walk through this whole new relationship, and anytime I had a question, I could reach out to anybody and I could ask questions and people were responsive. So I just want to say we're in it together. I am ignited and passionate about the work that we're doing. And now we're able to do things with clients that is amazing. I'll leave you with this story. It's just one of many, many stories. If anybody wants a tour, if anybody has questions, if you have, I specifically do things with staff. We build people up. We build clients up, or people we're working with. We build staff up because everybody matters. Everyone matters. And so here's a client, a person we were working with that I'd like to share. She came to us as a referral. She was 75 years old. She had been missing her leg from the knee down. And she was sitting in a wheelchair that was broken. And, she was utilizing pills for pain and had been labeled in the healthcare profession as somebody who was seeking drugs, prescription pills. She had 2 prosthetic legs that were in her closet. They were probably half her size, up like half her height, not usable. But as far as health insurance went, they found that she wasn't eligible for another prosthetic leg for 5 years or something. I'm not really sure about all that, the logistics of that. But really what this person had a car and a house, but she now had a dependent pill problem. And she also had medical trauma. So she was resistant to go to the doctor. So we'd set up appointments and she wouldn't meet us. And we'd go there. So what we did do, after spending much time, the staff at first met her with, oh, we got to work on your substance use. Oh, you're resistant to medical treatment. And I said, no, she's not asking you that. She's not telling you that. She wants to be able to walk. Her quality of life is affected and she has given up. She doesn't trust anybody. And the reason she lost her leg was she had an infected knee replacement surgery. And no one would listen until it was too late. So there was all of these variables in there. So I advocated with partnership. It went all the way to the medical director and at everybody at ECM and CS. We successfully were able to get her approved to get a new prosthetic leg. Didn't take very much. It took just communicating and saying what was true. We found her the best prosthetic doctor here in Sonoma County. And she has successfully obtained her leg. It's beautiful. She walks. She drives her car. I couldn't get a hold of her for like 6 weeks because she was in Arizona visiting her daughter that she went on a road trip. And her whole quality of life has changed. We're now able to get her into therapy. She's going to physical therapy. And so her use of prescription drugs has reduced. Her trust in the medical system has come down some, the distrust. So the relationships, and this person is walking and she no longer needs a new wheelchair because she doesn't need it. So those are just one example of what CalAIM, ECM, community supports, braided funding, Department of Healthcare Services, now the Path Cited, has enabled us to be able to wrap around a person without having to say, no, that's not our area. So I just wanted to share that one of many stories with you. It's super exciting. And I'm very passionate about the work. And the team that I get to work with is pretty amazing. So I just want to say thank you to everybody here who's been there and helping and supporting. Those of you that are in the trenches, hang in there. It gets easier. We now have workflow systems, and I know all the lingo to date anyway, because things always change, and we know that going forward there'll be new acronyms and it'll be a whole bit different story. But I just wanted to take the time and share that. And so I'm grateful we got invited to the table. I'm grateful that we are included in the work and that we're able to produce the work, and we're helping change people's lives, helping people to change their own lives. So I just want to say thank you so much for letting me come share today. And if you have any questions or want to know anything, you want a tour, you want anything, please feel free to reach out to me. I'm always happy to share resources and coffee. Anyway, so thank you for letting me share.
Thank you so much, Kim. That's an amazing story. And I think we do have a minute or two if anyone has questions or a comment or reflection they'd like to share. And I know Kim has shared a number of resources with us that we have on our website as well that I think many of you have been able to reference and utilize. So thank you.
I'll just say thank you. Thank you for all of your work. Thank you for your passion. And this is hard work, and I love stories. And so they're so powerful. So thank you.
Can I just say too, Kim, we don't know each other, but I really appreciated your presentation. And I was thinking these meetings, it's so easy to get caught up in the details of the workflows and ECM. And it's so lovely to hear someone that so clearly keeps the patient at the center of all their work. And I just really appreciated your story. Thank you for sharing.
I'd like to say a huge thank you in front of all of you as a group to Kim and her team representing CSN through the Housing Wellness Program. She's amazing, and the team is amazing. The work that they're doing is amazing. I myself, as the clinical director of the overall CSN, just love being able to go over and participate with that group and be part of it, and just to watch them grow and all the work that they're doing. I cannot be more proud of everything that's come out of this last year and where we're going. I can see it, and we're moving. It's not like we can just taste it. It's like we're going there for sure. So exciting. So thank you, Kim. Great job.
That is exciting. All right, well, I think I'm going to hand it over to Sue Grinnell, our director at Phil, to introduce our guests from DHCS.
Great, thank you so much. So before we dive in, I just want to do a little bit of framing. So we asked for representatives from DHCS to come and share information with you. We also have, over the course of just time, received questions, and we really are very committed to getting answers to the questions. So we will pose these questions to our two speakers, and then after that, we will have an opportunity from our curious participants to post things in the chat so that we can make sure that we get the opportunity to do that. So with that, I want to introduce our two speakers. So we have Randy Arias Fontenot, and she is a doctoral candidate and is a descendant of the Sandia Pueblo of New Mexico. And she's currently a resident of El Dorado County for 20 years, and she has a ton of experience in nursing, over 30 years of working in nursing in a variety of different counties in California. Randy has been part of the Department of Healthcare Services and Quality Population and Healthcare Management team, and as a nurse consultant 3 specialist since 2022. Her current work streams include enhanced care management for those transitioning from incarceration, members with the highest needs, members living in rural communities, and ECM for Native American members. She also provides consultation related to providing access and transforming health initiative, that's us, PATH, and CalAIM Incentive Payment Program, IPP. Welcome, Randy. And now I'd like to introduce Addie Sherman. And Addie Sherman has over a decade of experience working with clinical experimental psychology, specializing in developmental neuroscience, clinical outcomes, and statistical analysis. Within the Department of Healthcare Services, she is the Chief of Population Health Management Policy at Quality and Population Health Management. Current work streams include enhanced care management policy, population needs assessment, community health assessments, and community health investment plans, CHIPS, PHM monitoring, managed care plan contract compliance, and the PHM service, transitional care policy, TRIO benefit reporting, managed care encounter and claims data reporting, and the CalAIM incentive payment program. And that is a lot. That's a lot going on. So with that, I just am very excited that you are with us today, and I'm going to turn it over to Randy.
Good afternoon. Thank you all so much for having us. Truly appreciate being here. Absolutely love hearing the stories of those that are on the ground doing the work. And anytime you have the opportunity to hear a success story, it just really heartens you, and makes some of those longer days just even that sweeter, knowing that the work is out there, it's getting done, and that people are receiving this care. So again, thank you all for inviting us today, and we will do our darndest to answer all of your questions. If we are not able to do so today, we will certainly take them back to the team, and we will have them answered and get back to y'all. So I'm really excited to work with Addie today. So if we may have the next slide, please. And the next slide. Thanks. So a little just high level of Medi-Cal. Many of you are aware of everything that we offer. Basic coverage, including doctor's visits, prescriptions, dental, and vision care, mental health services, substance use disorder treatment, and so much more. Medi-Cal programs for low-income Californians who are pregnant, older adults, folks with disabilities, and with specific diagnoses. So to learn a bit more about Medi-Cal in general, you can always go to Benefits Cal or Covered California. Next slide, please. So a little bit about Medi-Cal by the numbers. 1 in 3 Californians do receive Medi-Cal. More than half of those individuals are school-age children. Half of California's births are covered by Medi-Cal, and more than 2/3 of the long-term care patients' days are covered by Medi-Cal as well. More than 65% of our Medi-Cal members are people of color. More than half of Medi-Cal spending is attributed to the 5% of members with the highest cost needs. And in many ways, you can kind of consider those some of our ECM patients. And about 20% of Californians are food insecure. And I would dare say that in current day, that is possibly higher than that, with money, approximately $7.2 billion annually spent in California healthcare costs are associated with food insecurity. So something we really want to take on. Next slide, please. So what are we trying to do here at DHCS? We are trying to, and doing our darndest to transform Medi-Cal to ensure that Californians are receiving not only the best medical care, but also addressing some of the social drivers of health so that each Californian, regardless of where they're located and who they are able to live their healthiest and best life possible. With this transformation, we are looking at new and improved benefits and services so that we can work with our members in a more holistic manner. In many ways, folks can consider this almost a moving, I don't even want to say moving away from a medical model, but enhancing a medical model, expanding that medical model to look at the patient in a much broader way and what are some of the needs that they have and how do we address those needs. And in doing so, we are looking at ways of housing support, medically tailored meals to support recovery from illness, and better integration and coordination of all of these forms of care, especially for those with their long-term care needs. Next slide, please. So some of the goals that we have, again, looking at a whole person care approach to address the social drivers of health, in addition to the physical needs of health, working to improve the quality outcomes and reduce healthcare disparities through a delivery system transformation. We are transforming Medi-Cal, and through payment reform, and trying to provide a consistent, efficient, and seamless Medi-Cal system. So really big goals. And you all are doing a lot of this work right now on the ground to make this happen. Next slide, please. So a bit of the Medi-Cal transformation overview, really looking to building a more equitable healthcare system for our members, with new providers and services that go beyond that. Again, the medical model, the doctor's office and the hospital. So looking at things such as, yes, physical health care, mental health and substance use disorders, dental care and vision care. So not deviating from those, but actually enhancing those services. Making these services more comprehensive and personalized, and coordination of care across all members. And more focused support on our members with those highest needs. Doing that through population health management, enhanced care management, community supports, and one that is rolling out soon, Justice Involved Initiative. Standardizing the benefits across the state so that all members, all Californians have the same access to same high quality care services, no matter where they live, whether they're in an urban location, a rural location, or anywhere in between. Doing that through behavioral health modernization, managed care plan transformation, Medicare and Medi-Cal plans, and then coverage for long-term services and supports. Next slide, please. So what are these initiatives? One of them is the population health management. Next slide. Population health management is one of the divisions that I personally am under. And what we're looking at is having Medi-Cal establish a cohesive statewide approach that ensures all members have access to comprehensive programs that lead to longer, healthier lives, improved health outcomes, and most importantly to me, health equity. And provide a comprehensive, accountable plan of action so that we can build that trust and meaningfully engage with those members, because we are aware that many of them, as we heard earlier, many of these members have not had the best outcomes in the healthcare system, and trust isn't always there. So how do we work to help to foster that communication, that connection, and that trust? Gathering and sharing timely and accurate data on member preferences and needs, so that they can effectively use their benefits and services that are out there. Connect the members to preventative care and other care management and transitional care services as they need them, and reduce the health disparities by linking members to public health and social services that address their specific health-related needs and social needs. Next slide, please. This is a little bit of a diagram as to and I will answer that shortly, Medi-Cal transformation for person-centered approach. So one of our ways is through identifying needs through risk stratification, prevention, wellness, looking at these for children and family, adults, people with disabilities, older Californians, foster youth, folks with medically complex needs, folks that are justice involved, people with serious mental illness and substance use disorders, those experiencing homelessness or housing instability, and then people at risk for institutionalization. And this is a bit of it's kind of a piecing together of a puzzle as to with the member focused, member in the center. We have two separate areas. We have the enhanced care management, and then we have the community supports division as well. So I'm under population health management and enhanced care management. We then have our sister group in community supports. And so oftentimes we may overlap in our work and or work directly together to help bring about these changes. Next slide, please. Also, we have long-term care services. Next slide, please. So statewide access to managed care, long-term care. We are required, Medi-Cal managed care plans are required to cover and coordinate long-term care in all counties. This started in 2023. Setting coverage, which included skilled nursing facilities. The goal by 2024 is that coverage will include intermediate care facilities for folks with developmental disabilities, and in addition to subacute facilities and pediatric facilities. The managed care plans will coordinate the comprehensive services, work to ensure that seamless care transition, and provide care at the most appropriate and least restrictive base setting for the members' needs. And I think we can't stress enough that least restrictive. What is their need and what gives that individual also the most autonomy based on their situation. And then ensuring access to ECM and community support services for our long-term care residents throughout the state. And ensure members that reside in community facility residences and receive support daily with living with ADLs or activities of daily living, including medication oversight and 24-hour on-site direct care staff. Next slide, please. A little bit about managed care plan transition. Next slide, please. So DHCS is transforming Medi-Cal managed care through multiple channels, and this is starting in 2024 with the new mix of high quality managed care plans available to members. So you will, in 2024, some plans will be entering and some plans will be exiting the system, depending on location. So there will be a new mix. Contracts with commercial managed care plans were announced back in December 2022. With operational readiness, which has been underway since January of this year, 2023. In addition, there will be model change in select counties, conditional approval for 17 counties to change their managed care model, including a new single plan model and expansion of county organization health systems model. We'll also have direct contract with Kaiser in 32 counties in which Kaiser operates, and based on provider plan linkage or population specific criteria for active choices. Assignments such as the dual eligible members as well as foster children, with the intent of this restructure to have a more robust contract implemented across all plans and all model types in all counties. Again, our purpose is really about health equity, quality, access, accountability, and transparency. And I really like to point out that this whole transformational process is a journey. It is not a destination. So we've had many different rollouts, changes, um, different versions and so forth. And it really is while there's a lot of change, I challenge you to view this as a journey. Our directive, Paula Barbieri, really reinforces that for us, that this is evolving. It's evolving to the needs of the members, and to all individuals out there that we are impacting. So it really is a journey, and it is a definite, I will readily admit as a nurse, it's a different change of mindset for myself, in which oftentimes something is implemented, we wait to see how it works out, and then it's done, right? It's over. ECM, enhanced care management, community supports, that is far from that at all. It is a journey. We will continue to keep evolving. Next slide, please. So some of the new requirements for our managed care partners, again, this is really to create a more robust managed care plan contract, and include strengthening. So key things: transparency, high quality care, access to care, the continuum of care. Where is that warm handoff? Focus on CalAIM initiatives. Again, extremely important to me, increasing the health equity and reducing those health disparities amongst the members, as well as culturally appropriate care. Working to establish administrative efficiency and minimizes administrative burden on members, on community-based organizations and managed care plans. Focus on behavioral health, children's services, really working on local presence and engagement, and addressing the social drivers of health. Next slide, please. A little bit more about these new requirements and how these contract provisions are in place. I will let you all have access to the deck when we're done, but just a few of them: transparency, publicly posting additional information about subcontractors, coordination of care, providing care management to all members based on their risk stratifications, and leveraging that broad data set and data exchange capabilities. We are still actively working on the PHM service to be able to help us with that data exchange, and you will be hearing more in the future on that as well. Next slide, please. Again, addressing the social drivers of health, and strategizing how do we meet our members where they are at, working on that food security and housing. Some of our most basic needs really impact the overall health of our members. And if we meet them where they're at and meet those needs, how greatly will that impact their health? As we heard in our example earlier, huge, absolutely huge. And how do we then see our members not just as a diagnosis, but in a much more holistic manner? Also having emergency preparedness and response plans to deliver that essential care. I think as we've all seen, especially those of us in rural communities, with the change in climate, how that's impacted various emergencies, fires, and so forth. And how does that impact our members? These are some of the most vulnerable Californians, and especially living in these rural areas, how can we provide for their security and ensure their safety as well as everyone else's? Next slide, please. So impact on Medi-Cal managed care members. Our goal is to have easy access to information. that can guide them in choosing the best plan for their family and friends and individual needs. As we know, managing the healthcare system is complex. So how can we simplify that so that individuals can choose what is right for them at that time? Really focusing and providing access to comprehensive person-centered health and social services. Our members will benefit from care and services that take into account their cultural, sexual orientation, gender identity, and preferred language. This is, moving away from a very cookie cutter presentation of what is important for that individual. No, we're coming to meet them where they're at and what are their needs and listening for that. Never straying from the physical health, but also integrating that with behavioral health care and narrowing that divide between the two and looking again holistically at that individual so that we can improve how we provide that care, both mental and physical, and including substance use disorder treatment. And then members who need that extra help will actually access to care management based on their healthcare needs, and expand preventative and early interventional services for children and infants. Next slide, please. So how is this managed care plan transition? Currently, DHS is currently involved in transition planning and stakeholder engagement efforts across a variety of different departments and areas of which we're currently rolling out. Our principles for this transition is to provide and ensure smooth and effective transitions, ensure a minimal disruption in services for our members, especially those in the most vulnerable groups and who are at risk, greatest risk for harm from an interruption in care. So really that's been a big concern of ours from the very beginning as plans enter and exit. How do we make that as smooth as possible? Provide outreach education to members through their managed care plans and proactively monitor the managed care plans, implementation of the transition of services. In 2020 or June 2023 of this year, DHS released an MCP transition program guide, excuse me, on continuity of care and member enrollment and other topics. So as we go into 2024, we can make this as seamless as possible. Next slide, please. Our dual eligible members, let's cover those a little bit. So integrated care for our dual eligible members are Medi-Cal and Medicare members. In January, 2 initiatives went live to support our statewide goal of improved care coordination. Also, Cal MediConnect plans transition to Medicare, Medi-Cal plans, Medicare Advantage plans, and enrollment for these plans open in 7 counties. Operates members' Medi-Cal and Medi-Cal plans, coordinates all the benefits, and provides members with integrated material and care coordination to help ensure continuity of care during this transition phase. Next slide, please. Next slide, please. So a little bit about the behavioral health initiative that went live. Specialty went live in 2022. No wrong door policy, July of 2022. Most recently for this year, we had health standard screening and transitional tools, recovery incentives, contingency management, behavioral health, payment reform, procedural tech codes, and as well as BH Connect demonstration. We can look forward in 2025, administrative integration of SMHs and substance use disorder for phase 2, and with the goal of being fully integrated in 2027. Drug Medi-Cal organized delivery systems, traditional healers, and natural helpers to be determined in the coming years. Next slide, please. So administrative integration, mental health and substance use disorders, clinical 24/7 access lines, administrative, state and county contracts, data sharing, EHR integration and redesign, cultural competence plans. Oversight is through compliance reviews, network adequacy, licensing, and certification. Next slide, please. And then this is a diagram giving a demonstration of how these services could be used, and prevention and wellness with children and youth, intensive outpatient, with assertive community treatment, peer recovery services, community services and supports through ECM, as well as behavioral health, bridge housing, and enhanced quality care, psychiatric hospitals and residential settings, and pre-discharge care coordination services. Next slide, please. Recovery incentives, through California's contingency management program. DHS is piloting Medi-Cal coverage of contingency management programs through Drug Medi-Cal organized delivery system. The individuals participate in a structured 24-week program, 12 weeks with twice weekly testing. They can earn a maximum of $599 over the 12-week period in the form of gift cards. Receive incentives for testing negative for stimulants, even if they test positive for other drugs, and then generate incentives and track progress through using an incentive managed software system. Next slide, please. Next slide, please. Justice involved. This is this is my wheelhouse. This is our Justice Involved initiative will be rolling out in 2024. We are the first state in the US that will be doing this work, and in providing 90-day pre-release services for enhanced for our Medi-Cal recipients, and linking them to enhanced care management. So there will be a linking between those services that they're receiving while incarcerated and those that they will receive at the point of departure. And our goal is to make that as seamless as possible, that those individuals will leave with all of the services that they need so that they will be able to reintegrate with a strong foundation for success. And so incarcerated individuals will be screened for Medi-Cal eligibility while in. Individuals will receive targeted services linked to mental health and substance abuse, and then the funding will be available for services that support reentry, such as the care management, full scope medication services, and medication assistant treatment. And the intent is really a key, strong, warm handoff between pre-release and then the post-release services. Next slide, please. And addressing these needs is really key to advancing health equity. These individuals have some of the highest mortality rates in the state of California. So through this connection, our goal is truly not only to see that individual through very holistically, but ensure that they have those safeguards in place so that they receive equitable care across the board, regardless of where they are at. Some of our statistics here, 28.5% of incarcerated males are Black. Latino men of other ethnicities. Black men make only 5%, 5.6% of the state's total population, and yet they have one of the highest mortality rates when exiting incarceration. That's not okay. Our goal is to overcome those numbers. Next slide, please. So thank you all so much for having us today. Hope we have plenty of time for question and answer. Addie Sherman is with me to give me a little break. and to also support in all of our questions and answers. Again, thank you all for all of the incredible work you're doing. We may provide information on these things. We may consult on these various work streams, but y'all are doing the work. You're out there, you're in the field, and I truly cannot thank you enough for all that you do and your partnership. Definitely want to put a plug in for past cited funding. Please, 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 please apply. That is a work stream that I am on and in review of applicants. And I cannot encourage you enough to apply. So please, 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 please apply. Thank you.
Great. Thank you so much. So we have time now for questions, and we have questions that we've received from you all on slides. So we're going to start to go through those. I want to, though, also just be mindful that we hopefully will have some questions in the chat. So we may not get to all of the questions on the slide, but hopefully Addie and Randy, you will help us get those answered and get them back to everyone in written form. So thank you. Yes, please, if you have any questions, I'd love for you to put them in the chat. So what is the DHCS vision for how MCPs can best support a successful implementation of care coordination, navigation, and referrals across all health and social service providers, including community supports providers? It's a big one.
Hi, yes, thank you for that. And thank you so much, Randy, for leading that presentation. So I'll take the lead on some of these discussion questions. First of which, I think the DHCS vision overall for all of our care management and population health management initiatives is to really reorganize how we look at healthcare and kind of start to build up from the ground up these relationships between, local health entities, community organizations, and managed care plans. So our vision is definitely, coming to the table with at these, discussions and beginning to talk among different parties and make sure that we're building the infrastructure that we need to start a lot of these kind of referral and navigation processes. I'll say during 2024 especially is when we hope to facilitate a lot of these discussions and building of partnerships, as we will have some of the closed loop referral policy also rolling out in 2025. So hopefully we will use, memorandums of understanding, more presentations and great talks like this to hear feedback, and hope to facilitate this process as much as possible.
Thank you so much. Let's go to the next one. And none of these questions appear to be short.
That's all right. They're great questions still.
Yeah. So how is DHCS aiming to support systems interoperability for CBOs, tribal entities, and organizations that serve historically underserved populations with traditional healthcare providers without them having to compromise culturally appropriate services or unreasonable cost burden?
Yes, this is a great question as well. I think a main priority of ours definitely in the last couple of years, and as we roll out a lot of the PHM policy in 2024, is surrounding interoperability. So we definitely have that in mind. I mean, in all of our policies and procedures that we're rolling out, we've been working with managed care plans to set up policies around interoperability to hopefully help with the burden that our, community partners and tribal partners are experiencing. I will say another big piece of this is the reimagining of the population needs assessment that's been in development this past year. And we are really trying to reorganize it in order to, while keeping cultural and linguistic necessities, also creating a more holistic view of social drivers of health, upstream interventions, and things that are happening in the community, and how to leverage these processes so that we're not, duplicating the effort of having these top-down initiatives and instead are looking to, support and utilize processes that are already doing a great job in assessing needs in our communities.
Great, thank you. I think just in the interest of time, we have about 10 minutes or so left for this. I want to just be mindful of the questions in the chat. So if we want to take down the slides, Catherine, are you willing to
Sure.
yeah.
So Catherine Couch Series Community Project. I was intrigued by the comment about standardized benefits across the state and local presence. We're in partnership counties and now have Kaiser coming in as a direct contractor. And I've been told directly by Kaiser that, well, I'll just say, I am concerned that Kaiser is not going to contract with locally based organizations for the meal benefit, as well as other benefits, and that they're not going to meet the eligibility guidelines or the intervention design that partnership is using. And I think it is going to lead to an unequal access to services among Kaiser, the patients who are moving to Kaiser. And I'm really curious about how DHCS is going to manage Kaiser as a direct contractor and provide oversight about how Kaiser is actually going to engage and partner with locally based organizations.
That is a great question. So I will say, this whole transition of care models in 2024 is obviously a huge undertaking. And there are actually other teams that are devoted to this effort that I would love to put you in contact with that hopefully will be able to give you some more specific information. What I can speak to is that, we are developing audit and investigative procedures for population health management policies that we will definitely be following up with, and always are open to concerns and working together to hopefully, avoid some of the conflicts and the problems that you mentioned. But I will put our email in the chat as well. So feel free to reach out to us there and we can forward you to the team that is specifically working on, Kaiser's partnership and the managed care plans transitions in 2024.
Great. It's a really, really important question, I think, and we need to get on it fast.
Absolutely.
For lots of reasons. So thanks. I will definitely reach out.
Yeah, thank you so much, Catherine, for your question. Okay, here is the how many $1 million question, not really sure on the estimated release for the PATH cited round 3 grant funding opportunity. Do you happen to know when that's going to come out?
Great question. So the applications will begin in January. So acceptance of the applications will be in January 2024. As for release of funds for round 3, that is still in the works. So don't want to promise a hard, fast timeline for that. But the application process begins in January. So
great, thank you. Amy Anderson. She's got some questions.
I do, and I'd like to ask you both about the upcoming 2024 Populations of Focus, one for the Justice Involved and then the birth equity. I'll start with Justice Involved because that's your sweet spot. It's my understanding that the pre-release Justice Involved initiative depends on county probation either having staff that they hire or contracting out. And if they choose to contract out that service, that is the expectation of DHCS, that contracted provider would then provide the post-release ECM services as well. And given that the pre-release has been pushed back to October of 2024, what does that mean for January 1 for the start of the justice involved population of focus for ECM? Does that make sense? And you're muted, but I really want to hear the answer. Still muted.
Randy, are you
There
able
we
to?
go, there we go.
Yeah.
Oh, there you go.
That was a very hard mute. So it is a great question, and I just want to make sure that I'm understanding it, that I'm going to get all the components to it. So push back until October. You want to know about the contracting. If they're contracted, are they going to provide pre and post?
Right. So it's my understanding that because JI, as
Right.
most of us know in this room, is divided into the pre-release services, which are amazing and need to happen, and then also in the post-release services as well, as an ECM population of focus. So the pre-release for justice involved and the post-release for ECM. It's my understanding in the policy guide that came out, and then with pushing to October, that if the probation or the sheriffs or whoever is running the county jail, if they contract their pre-release services, that it is the expectation in the policy that's written for the JI initiative that post-release would also be provided, if at all possible, by that same entity. And since that's not happening for at least 10 months with a rolling, what happens January 1?
So January 1 is, again, it's rolling. So there are some areas that may go live that are already prepared. And there are others that may not be. So January 1, it is just all about preparation, an estimation of who can do what, and what their plan is. So that's what we're looking for. We're not, we don't expect we're looking at estimates of members served, who will be providing these services, are those contracts in place, and then are relationships being built.
So if because I want to be really mindful of time. If I want to provide post-release justice involved ECM services, and my county hasn't made the determination whether or not they're hiring their own staff or they're contracting out for services, can I provide post-release ECM justice involved services in January, regardless of what my local probation office, sheriffs, whoever's running the jail is doing?
Great question. Addie, any thoughts on that? Because I don't want to,
I would have to take that back, but I believe
Yeah.
post-release services are going live in Jan 1, and it's just the pre-release services that are being pushed back till October. So please email our mailbox that I just put in the chat. I am fairly certain that you would be able to, but I don't want to give you a definitive answer without first really making sure.
Okay, but my question, I want to make sure the question makes sense, because I realize I'm super in the weeds on this one.
I think that makes sense. Yeah.
Okay, because I just don't want to set up a program and then in October lose the program because the county went in a certain direction.
Right. And I will say too, I mean, the incentive payment program definitely has some measures around justice involved population as well that, we are hoping that people will be providing services and still building up their contracting, and will be, hopefully rewarded for doing so.
I know Case is going to ask about JI because we are in the same meetings together. So if I cede to him for JI, can I come back for my birth equity?
No, I think we should finish your, because you have a question about birth equity population.
I do, and it's a very similar esoteric in the weeds question. And
I will say neither Randy or myself are working on birth equity at the moment, although please email our mailbox and we will put you in touch with our team member who is leading it and would love to get you more information offline.
So would you rather I not ask the question right now?
I mean, I don't think Randy and I would be able to
I
give
think
you
it
a
would be
definitive
good,
answer.
maybe. I mean, this is just me. I think we want to know what the questions are.
Oh, sure. Yes.
Yeah, so that we can help to track them, because I would venture to guess other people besides you, Amy, might have that. So we just want to be able, so please ask your question.
So I've been noodling around in the mortality and morbidity for birth equity for people who are pregnant, trying to look at what population might be there, because it calls out Black, Alaskan, and Native American, but it's particularly bad for those who list themselves as mixed race. So is that something that gets wrapped in? Also, if you are in an area where you have less access to prenatal care, would that access help, or is it just on the equity? According to CDPH, if you have Medi-Cal, you're 2.8 times as likely to die giving birth than you are if you don't have Medi-Cal. So in and of itself, having Medi-Cal almost puts you in an area of inequity, just because of all the other things that you have. And so trying to also look at what that looks like, and I understand that you guys are not the experts here, but we're like a month away from that starting. And if you're somebody who is serving a population that doesn't fall into the two ethnicities that we're focused, but have a lot of inequities for other reasons, where is that flexibility with, because I know the plans are getting less flexibility based upon what you all talked about in August. So where are we mapping out what it looks like? Because it's not clear in the September 23 policy, nor in the documentation before that. So those are my questions, and I will try to make them sound intelligent in an email.
I've got faith in you.
Thank you, appreciate that.
Yes, no, those are great questions, and we really appreciate them. And you know, they always go toward knowing more about what we could be more clear on and release like FAQ and stuff like that if we need to. So yes, please send that question to our mailbox, and we'll get you connected with the Birth and Care Pathway and Birth Equity folks as soon as possible.
Okay, Casey, I see your hand up. If it's okay with you, I'm going to do one of the questions in the chat, and then so don't put it down. Okay, so Joni has a question, and it's for the group, right, or DHCS, about technology platforms. Joni, do you want to speak this? Just a little bit more context. I see you, Joni.
Hi, I'm sorry about the mute button. So my
I know.
question really, really just had to do with the technology platform. And I wanted to know if the services or the CBOs that are instituting or standing up care management programs specifically, is there one that people are landing on? Because if there's care management programs where CBOs are especially working across counties or across health plans, are they just making it data exchange framework friendly and connecting with all of the health plans, or is there something that everybody is landing on for care management? That was my question.
Yes, right now I'd say it's really dependent upon the managed care plan and their contracted partners. I've seen a lot of different uses, but I will say in the next couple of years, we are hoping to roll out the PHM service, which is going to be a comprehensive technological platform that will have, you know, access to various different social services and medical services data, and also will include our developed risk tiering and stratification that folks will also be able to use in order to identify members that are especially in need of care coordination and management, and things like enhanced care management.
And which organization specifically will be rolling that out?
That's DHCS.
Oh, okay.
Yep.
Fantastic.
So it'll be for all Medi-Cal beneficiaries.
So whatever we do now is sort of a temporary solution until there's a comprehensive pop health solution that comes out from DHCS over the next 2 years. Is that accurate?
Right, right.
I
Yes.
got
Right
it.
now, we are partnering with managed care plans for them to use their own kind of risk tiering and tech platforms in order to, manage the care needs of their populations. And then we will be rolling out a comprehensive platform as well that plans can
Perfect.
either use as like an additional benefit and keep using their own system, or they can just use our system.
I
There.
think this is great, and it makes me think that this is really a big issue. I know yesterday, after some of the things that were related to this, there was some follow-up questions, right, and maybe some concerns. So I think it might be great to either have you, Randy, and Addie, or somebody, right, that could speak to that about this 2025 rollout. But Casey, thank you for being so patient.
Of course, thank you. And thank you, Amy, for always asking the great questions. Mine's going to be also kind of an additional in the weeds off of Amy's question, as we are providing ECM services for the JI POF in a county, and the county has already told us that they are expecting us to support the JI POF starting 1/1/24, which we are okay to do. But the county does not have someone that's doing the pre-work at all. So we're going to have members that are exiting into the community that have not applied for anything. So then while we're trying to support and enroll them and get them enrolled in Medi-Cal, has DHCS issued mandates or expectations to the MCPs that is presumptive eligibility is expected, required for the GI POF, so that way we're still able to bill for service versus providing services. I guess that's more, I'm trying to figure out, can we provide service while we wait for the members eligible, or do we have to tell them you have to wait 90 days and hope we don't lose the member? What is the plan around that part of the specific? And again, I know this is very into the weeds, but we do have a county that's expecting us starting 1/1 to support with all those exiting incarceration.
I would say at the moment, please reach out to our mailbox, and would love to get you in contact with some of our additional justice involved partners that I think have been, working historically with these populations and would be much better able to give you the specifics on something like that. But thank
Okay.
you so much for asking.
I know that we are out of time, but I am looking, sorry, Catherine, I'm just looking, I know funding is always anxiety provoking, at least it is for me. And I'm seeing there's a lot of questions in here about funding. One is, if you know, where can we apply for the incentive funding? The other one is related to cited funds and a range of when if the funds might be released. Would be helpful.
Okay, I was about to respond to that in the
Oh,
chat.
good. Okay.
I'm really sorry. I am connecting as we're speaking here with some of our other PATH folks, PATH cited funding. And we absolutely, at this time, it's still in the works. I would love to give you a range, but I do not know when those will be released for the third round. As far as where you can, I can pop into the chat here.
Incentive funding was here. Where can we
The
apply?
other for the IPP funding, that is an, Addie, confirm with me,
Yeah.
to make sure that is through the managed care plans.
Yes, so the incentive payment program is unfortunately only for managed care plans that we contract with at the moment. However, it is going to play a role as well in our community investment program. And I think there are still opportunities of, making sure that your managed care plan knows that in what cases you'd like to provide services, because that will, trickle down to also providing funding to you.
Right.
Is the hope.
Yeah, that's interesting. Okay, so I think I'm going to turn it back over to Catherine, and we will commit to getting these questions down and making sure all of DHCS can respond and help us to get the answers and get them back out to you. So thank you. Catherine.
All right, thanks, Sue. And thank you so much, Randy and Addie, for joining us and for answering so many questions. So I'm going to turn it over to, I believe, Lynn Scurry, or is it Ashley and Bianca today? Because I saw Lynn on here. To provide from Partnership Health Plan to provide updates and on process improvements.
I'll take it, Catherine. Thank you. Hi,
Thanks,
everybody.
Ashley.
Yeah, of course. Hi, everyone. Good to see you all. My name's Ashley Peel. I am a program manager on the ECM team at Partnership. And we just have a few little updates and resources to share with you today. So if you'd go to the next slide, please. Okay, so our biggest one, I want to call out that unfortunately we did have to postpone our referral source webinar that we had scheduled for tomorrow. We just heard of a conflict for one of our regions that would lower our participants. So we decided to push that out. We did pick a new date yesterday. So you should have received an email with a new flyer and registration link. Due to everything that is already scheduled for December and also the holidays, we did push it out to January. So if you did not receive the link and you are interested in attending, we'd be more than happy to share that with you. We are going to be providing a transportation benefit overview. We put December or January, however, we are in the final phases of getting a flyer ready for December. So I believe it's December 19th, kind of a quick turnaround. Our communication team is approving the flyer right now, and then we'll get that sent out as soon as possible. But this is just our transportation department providing a brief overview of how you can connect with them to set up rides for members. We did hear that this week they hired a lot more staff and have heard that the wait time has decreased significantly. So we're excited about that. We will also be providing an Excel basics for our ECM providers. That webinar is going to be held in the next couple of months. We selected 2 dates, and you should have received a doodle poll today with those 2 dates, and we will move forward with the date that works the best for everybody. But that Excel basic webinar is just going to be going over the basics for how you can use these tips and tricks for completing your reports. So how to make sure that the SINs don't change to a scientific format, how to avoid those drop downs being locked, those kinds of things that we think will be helpful. And then we will also be focusing on the birth equity and justice populations of focus next month during the CPIs. So we are working feverishly since we are right around the corner from January, developing processes, referral processes, how reporting is going to look, all of those things. So more to come on that. Next slide, please. Okay, and here's just a few resources for you. Once again, we have our ECM and community supports webpage, lots of helpful resources there. There is recorded webinars if you're interested, if you need a refresher on a training, lots of things there for you. And then also our department phone numbers if you are needing any assistance. With ECM, if you call into our care coordination department, they are able to pull up the members' information and help you. They can also contact the ECM team if needed. The transportation services department if you need to schedule a ride for a member, and then our provider relations and our claims customer service phone numbers. And I believe that is all I have as far as updates. Are there any questions for me?
Ashley, I see that Aura said that the link allows registration, but it's not sending an appointment or confirmation email. I'm assuming that will be fixed when the new date is announced for the, I think it's the best practices webinar.
Let's see, registration, but it's not sending an appointment or confirmation email. Aura, is this for the referral webinar?
It is. It's the flyer that got sent out yesterday. And I thought I'll get something overnight, but I didn't get anything. So I don't know if there's a little glitch in that.
Okay, perfect. I will check on that registration link and make sure that it's getting confirmation sent.
Great. Thank you.
Of course.
Well, thank you so much, Ashley. And, if anyone has questions, feel free to drop them in the chat. I'm going to move us along because we want to make sure we have time to hear from you. I believe Stephanie dropped a link to our event survey in the chat. We're going to spend a few minutes together in the meeting to allow you guys some time to fill it out. Please do fill it out. It is really helpful to us in terms of planning programming and really learning where and how we can best support you. So you can scan the QR code, you can hit the link in the chat, but it should only take a few minutes. And again, we really appreciate this information, and it really does help us. So as you're filling out the survey, which I know you're all busy doing right now, we do have a couple of upcoming events we wanted to go through with you. Next slide, please. So our next CPI monthly event will be virtual. And for this group, it's going to be on Thursday, December 21st at 1 o'clock. And as mentioned by Ashley, they are still conducting their ECM roundtables, and I did see a link in the chat to where you can register for those if you have not already registered. And if you were unable to attend the last ECM roundtable and want a copy of the chat, there's always such great Q&A that goes on in the chat. Just let us know and we're happy to send that to you. We are also having office hours this month on December 7th and December 11th. They're pretty informal. It's just an opportunity for you to show up and chat with us. Bring your questions, your pain points, your big wins, anything you would like. We usually only get a couple people, which is nice because then we're really able to spend time and dig into what's going on and how we can best support you. And if we're not able to do so, during that actual office hours, we're really committed to trying to find the support and answers that you need. Next slide. I think as you saw in the chat a few times, and you should have received an email yesterday, we are going to be having a pop-up event next week on December 5th. And it's just an info session with Kaiser Permanente. We're going to have Arif and I think a few others that will be coming from Kaiser to sort of present on what to expect during the transition and also be available to ask questions. So I saw a lot of questions in the chat and we had some questions we discussed earlier. So I really encourage you to come. And if you're not able to make it, please feel free to send any questions to us either via our path@pop health email, or if you click on the registration link that was sent out yesterday, you're able to add questions to that form that we can, collect and collate and hand over to Kaiser as well. And we will record it. So if you cannot make it, then you would be able to watch all of the fun on our website after the event. Next slide, please. There is another pop-up event that we wanted to highlight. DHCS is hosting a statewide PATH CPI best practices webinar on relationship building with organizations in the CalAIM environment. And you all are invited to attend, and it's really an opportunity to learn from many other organizations and individuals that are doing this work across the state and, their lessons learned, the best practices that are working, and it might be an opportunity for you to learn about something that will help you do your work better. Next slide, please. Well, I think that's all we have for programming. So Katie, if you want to go back to the survey slide, just in case you missed the link or the QR code, please do take a few minutes to fill this out. And I will stop talking so that you can have quiet time to complete the survey. Thank you, everyone.